Assalamu alaikum everyone. My name is Youssef Elshimy. I'm a fourth year medical student, and today I will be giving you guys an MSI miscellaneous crash course. So in this crash course, I'm going to cover a lot of topics, including anatomy of joints, physiology of bone, temperature regulation and fever, as well as the five LGD lectures, which includes fractures, bone pain, arthralgias, neuromuscular injury, as well as orthopedics and sports. And I'm also going to cover the six lectures of sports medicine, which includes the upper and lower limb MSK trauma, joint and ligament injury, as well as approach to patient with sports injury and deformities. So hope you guys benefit from this crash course. All right, starting with the anatomy of the joints. So a joint is the site where two skeletal elements come together or where two bones meet. And we have some terminologies that we need to cover. The study of joints is called arthrology. So since we're currently studying joints, we're doing arthrology. Then kinesiology is the study of joint biomechanics. So anything related to the physics and the movement behind joints is called kinesiology. Whenever inflammation of the joints occur, it is called arthritis. And I'm pretty sure by now you guys have covered all types of arthritis, things like osteoarthritis, rheumatoid arthritis, gouty arthritis, as well as septic arthritis. So joints are frequently involved in traumas like fractures, dislocations, as well as a lot of disease conditions. So it is really important for you guys to understand the normal anatomy of the joint in order to be able to understand what conditions or what abnormalities may arise that could affect these joints. Starting with the functional classification of joints. We can classify joints according to their mobility. So some joints are immobile, they don't move at all. Some joints are slightly mobile, they move a little bit. And some joints are freely mobile. So starting with the immobile joints, which are called synarthrosis, these include bony joints, fibrous joints, and primary cartilaginous joints. Then we have the slightly mobile joints, which include the secondary cartilaginous joints. And the way to remember this is that there's S here as well as S here. So slightly mobile joints are secondary cartilaginous joints. Then we have the freely mobile joints, which are called diarthrosis. These include the synovial joints. And synovial joints are most commonly found in the appendicular skeletal system in our body. So they are found most commonly in the upper limb as well as the lower limb. So starting with fibrous joints, and we mentioned that these joints are immobile. They include three main entities. We have the sutures, we have the gum fosses, and we have the syndesmosis. Starting with the sutures, and they are found only in the skull. So in the skull, we have different bones, and whenever these bones meet, they form sutures or suture ligaments. These sutures are considered fibrous, immobile joint. And as you can see here, it is basically a dense fibrous connective tissue that joins the bones of the skull. Then we have the gum fosses, which is the joint between the teeth and their sockets. And it is usually called the periodontal membrane, which is the membrane that joins the teeth with the socket. And it is also considered a fibrous immobile joint. Then we have syndesmosis. So some bones are joined together by an interosseous membrane. Think think about ulnus and the radia. They are joined by an interosseous membrane as well as the tibia and the fibula. So this interosseous membrane is called syndesmosis and it is considered a fibrous immobile joint. So to recap, we have three types of fibrous joints. Fibrous joints in general, they are immobile. This includes the sutures, which are the linings or the joint that joins the bones in the skull. We have the gum fosses, which is the joint between the teeth and their sockets, as well as the syndesmosis, which is the interosseous membrane between bones like the ulna and the radius, as well as the tibia and the fibula. Then moving on to cartilaginous joints. And we said there are primary cartilaginous and the secondary. But we're going to discuss first the primary cartilaginous joints, which is called also synchondrosis. And you have to know that they are joined by hyaline cartilage and they are immobile and they are often temporary. So an example is the epiphyseal plate that joins the epiphysis and the diaphysis. It's basically at first a joint, a primary cartilaginous joint, but later it ossifies and becomes a bone. And another example is the union between the rib as well as the costal cartilage. So to recap, the primary cartilaginous joints are immobile. They are joined by hyaline cartilage. And an example is the epiphyseal plate joining the epiphysis and the diaphysis, and the union between the rib and the costal cartilage. Then we have the secondary cartilaginous joints. They are also called symphysis. You have to know that they are joined by a cartilaginous disc. We mentioned that since there's S here, so they are slightly mobile, and they are usually found in the midline of the body. So an example is the manubriosternal joint, which is the joint between the manubrium and the sternum. And we have also the symphysis pubis, or the pubic symphysis, which is the joint that joins the pubic bones. Finally, we have the intervertebral discs, which are the discs between vertebrae. So, so they allow a slight movement. For example, in the manubriosternal joint, whenever the rib cage expands and whenever you breathe, this manubriosternal joint slightly moves. And we have also the pubic symphysis, especially during the pregnancy and delivery. It also slightly moves and expands. And finally, we have the intervertebral discs, which also slightly moves during the movement to allow a more flexible trunk. Okay, so moving on to synovial joints, and we mentioned that the synovial joints are the freely movable joints. And in order to form a synovial joints, we need certain characteristics. First, starting with the articular cartilage, or the cartilage that lines the articulating surfaces of the bones. So the type of cartilage is hyaline cartilage. It is found in most, if not all, synovial joints. Some atypical joints, they use fibrocartilage, but you have to know that synovial joints are lined by hyaline cartilage. Then we have the joint capsule, which surrounds the joint. And as you can see, this is the layer, a fibrous layer that surrounds the joint, forming the joint capsule. And whenever we have a capsule, we have a space inside. So we have the joint cavity, which is the space that contains the synovial fluid. Okay, so how is the synovial fluid made? It is made by the synovial membrane, which is the blue layer lining the internal capsule, as you can see. And this is responsible for secreting the synovial fluid. Then we have some ligaments, either internally or externally. And these ligaments are important for stabilizing the joint as well as reinforcing the capsule. Then we mentioned about the movement. We mentioned that synovial joints are freely movable, so they are capable of varying degrees of motion. Some joints have an intra-articular fibrocartilage disc, and this allows more shock absorption and more stability. So you have to know from this slide is that hyaline cartilage covers the ends of the bone in synovial joints. There's a capsule inside the cavity that contains the synovial fluid. It is secreted by the synovial membrane, which lines the internal capsule. Then we have some ligaments that reinforce the stability of the joint. Then we mentioned that synovial joints are freely movable, so they are capable of degrees of motion. Moving on to synovial fluid and accessory structures. We mentioned that synovial fluid is secreted by the synovial membrane and it has a lot of functions. It allows lubrication, nourishing chondrocytes, so giving nutrients to the cartilage cells, removing wastes, reducing friction, and helps with shock absorption. And also, synovial fluid is important clinically because a lot of conditions affect the characteristic and the consistency, as well as the type of cells that are found in the synovial fluid. So it is very important clinically whenever we do joint aspiration to check for change in synovial fluid. Then we have some accessory structures. The doctor had a whole slide, but he didn't stress that much. But I would like to stress on three things. We have the labrum, which is the fibrocartilage ring that deepens the sockets, especially the hip and the shoulder. So the hip and the shoulder, they are a bit shallow. So in order to make this joint even deeper, we have a labrum. This labrum is a fibrocartilage ring that deepens the socket. So, for example, this is the joint. So what happens is that the labrum deepens the socket to allow more surface area for articulation and more stability. So it's basically a fibrocartilage ring that deepens the socket to allow for a more stable joint. Then we have the meniscus, which is a crescent-shaped disc. It is found only in the knees, as you can see. This is a crescent-shaped disc, and this also provides stability to the joint. Then we have the bursa, which is the fluid-filled sacs that reduce friction between tendons and bones. So that fluid in general, like synovial fluid or the fluid-filled sacs, they reduce the friction between structures. And bursa is basically a fluid-filled sac that reduces the friction between tendons and bones. Okay, so we can also classify synovial joints, but before we classify, we just need to recap that synovial joints are freely movable. They are diarthrotic joints. They permit a wide range of movements, and movement depends on the joint structure. So we can classify the joints according to their shape or the structure, or according to their function, which means the type of movement allowed. So we have different shapes or structures. We have the plane gliding joint, we have the hinge joint, we have the ball and socket, saddle, condyloid, ellipsoid, which is also called ellipsoid, and we have the pivot. And these joints allow for certain movements. So, for example, the plane joint allows for gliding movements. The hinge allows for flexion and extension, etc. We're going to cover each type or each shape of the joint, and we're going to mention the function or the movement allowed. Starting with the plane joint. And as you can see, the articular surfaces is basically flat or slightly curved. And it is just a gliding movement. So the movement is a non-axial. So there's no axis in which the joint moves. It's just basically gliding. And the range of motion is small and limited. So it's not a very movable joint, although it is considered a freely movable joint. And examples include the intercarpal joints, as well as the intertarsal joints, as well as the acromioclavicular joints. And a joint that the doctor mentioned in the slide is the joint between the clavicle and the manubrium. Then we move on to hinge joints. And as you can see, the articular surface is the cylindrical surface that fits into a trough. And the movement is just flexion and extension. So, for example, the elbow joint, as you can see, you can flex and extend. And this is also a movement that is uniaxial or just moves in one axis. And an example is the elbow joint, as we mentioned, and we have a knee joint. But a special thing about the knee joint is that it is a modified hinge. So although it is still a hinge, but it is modified hinge because it allows not only for flexion and extension, but it allows for limited rotation. So that's why it's considered a modified hinge. Then we have also the interphalangeal joints, which are hinge joints. Moving on to ball and socket joints. So the articular surface is basically a spherical head that fits into a cup-like socket. And this is the most movable joint. So it allows for flexion and extension, abduction and adduction, rotation, circumduction. So it's a multi-axial joint. And an example is the shoulder joint, which is also called the glenohumeral joint, and the hip joint. And these joints are very prone to dislocation since if there's more freedom, there is more risk of this joint being dislocated. Moving on to saddle joints, we have the articulating surface, which is a concave surface fit into a convex surface. So the movement is flexion and extension, abduction and adduction, and circumduction. And it is considered a biaxial joint. So it moves in two axes. So a classic example is the first carpo-metacarpal joint, which is found in the thumb. This is considered a typical saddle joint. Moving on to ellipsoid or condyloid joint, where the articulating surface is basically the oval convex surface fit into the oval concave surface, and it allows for flexion and extension, abduction and adduction, as well as circumduction. It is also considered a biaxial joint, and an example is the wrist joint, which is the radio carpal joint, and the metacarpophalangeal joints. Lastly, we have the pivot joint, which is basically a rounded surface rotating within a ring. And basically, the movement is that the rotation happens around a single axis. So it's a uniaxial joint. An example is the atlantoaxial joint, which is the C1, C2 vertebra, and also the proximal radio-ulnar joint. And here it allows us to rotate around the single axis, and the radio-ulnar joint also allows us to do pronation and supination. Okay, so now we can classify the synovial joints according to their function, or according to how many axes they can move across. So we have the non-axial joints, which means that the joints that do not move in a certain axis, and we mentioned that they are the plane or the gliding joints. Then we have the uniaxial joints, which means they move in only one axis, which include the hinge joints as well as the modified hinge joints. So things like the elbow, the knee. Then we have the pivot joints, which includes the atlantoaxial joint as well as the proximal radio-ulnar joint that I mentioned here. Then we have the biaxial joints, which are the joints that move in two axes. This includes the ellipsoid, or which is also called the condyloid joints, as well as the saddle joints. And finally, the multi-axial joints include the ball and socket joints. So last slide regarding the anatomy of the joints, it's a clinical slide. So whenever a patient have joint inflammation, you look for the cardinal signs of inflammation, which includes redness, hotness, swelling, and pain. In Latin, is also called rubor, calor, tumor, dolor. And specifically pain, you have to rule out or know where's the pain coming from. So is the pain coming from the joint itself? Is it bursitis or inflammation of the bursa? Is it the muscle itself that is causing the pain? Is it the tendon or the ligament? Or if it's a referred pain from another structure. So based on history, physical examination, and investigations, you can know where is the pain coming from. Then I want to add the fifth cardinal sign of inflammation, which is the loss of function. And you know that the function of joints is movement. So whenever there is loss of function, there would be reduced range of motion. So whenever a person comes with a joint problem or signs of inflammation of the joint, you have to assess whether there is pain or not, there is heatness or not, there is redness or not, there is swelling, there is loss of function by reduced range of motion or not. Moving on to bone physiology. So we know that bone has a structured frame, but it has a lot of other physiological functions. So, other than providing mechanical support, enabling movements, and protecting vital organs, it has a lot of physiological functions. So, things like hematopoietic functions, because it houses the bone marrow for blood cell production. It has also an endocrine function by producing hormones that regulate energy metabolism, and it acts as a mineral storage. So, 99% of our body's calcium is stored in bones as hydroxyapatite crystals, as well as phosphate. So in this diagram, you can see that 99% of calcium is stored in bones. Then we have 1% that is stored in soft tissues. And out of this 1%, 0.9% of calcium are stored in organelles, and 0.1% they are found in the extracellular fluid as well as plasma. Then from the 0.1%, 55% of the 0.1% is ionized calcium, which is the free calcium that does our physiological effects in our body. And it is tightly controlled. So you have to tightly control the level of ionized calcium in our body. Then we have the 40 to 45%, which is the protein-bound calcium, or complex calcium, like calcium carbonate, citrate, phosphate, etc. So moving on to bone cells, we have three main types of bone cells. We have the osteoblasts, we have the osteocytes, and we have the osteoclasts. Starting with the osteoblasts, they are the master cells. They are the bone forming cells. So they form bones by depositing the organic matrix. And the first bone that is laid is called the osteoid. Then we have the osteocytes, which are the mature bone cells. They come from former osteoblasts that are trapped in the matrix, and they have an important role in acting as mechanosensors. So they detect any stress and regulate bone remodeling, and they also control the local calcium and phosphate levels. Finally, we have the osteoclasts, which are the specialized macrophages derived from the circulating monocytes. And you know that macrophages, they like to eat. So they are large, multinucleated bone resorbing cells. So they like to eat bones. And they do that by secreting acid, which is the hydrogen ion, as well as proteases to dissolve the minerals, as well as to degrade the bone matrix. So, bone remodeling is basically recycling of the bone. So, it's a continuous process in order to maintain the bone strength as well as the calcium levels. How is it done? It is done by bone resorption, and the key player is the osteoclasts. So, osteoclasts, they create a resorption pit or the construction site in which they secrete hydrogen ions as well as enzymes like capsin K to dissolve the bone. Then comes the bone formation, which is done by the osteoblasts. And those line the cavity and deposit new bone matrix until the space is closed. And this is a coupling process that is tightly regulated. We have a lot of signaling molecules that, like the rank L, as well as the OPG that we're going to talk about. So it's a tightly regulated process that includes bone resorption and bone formation. So bone remodeling is regulated by mechanical stress sensed by the osteocytes, as well as hormones like the parathyroid hormone, thyroid hormones, as well as the sex steroids, and signaling molecules like the cytokines and growth factors. So let's talk about the most important pathway for bone remodeling, which is the rank L, and the OPG pathway. So let's start. The osteoblast is the master cell. So osteoblasts and osteocytes, they secrete rank L or the rank ligand. And the ligand likes to attach to receptors. So what happens is that the rank ligand attaches to rank receptors on osteoclasts. And whenever that happens, the osteoclast differentiation happens as well as activation and survival. Okay. Another thing is that osteoblasts, they secrete the macrophage colony stimulating factor or the MCSF. And this also stimulates or activates osteoclasts. So whenever there is increased rank L or the MCSF, it would lead to more osteoclast activity or more bone resorption. Then, as a counterpart, or on the other side, we have the OPG, which is also secreted by osteoblasts. So, OPG acts as a decoy receptor. A decoy receptor attaches to the rank L. So, whenever the OPG attaches to the rank L, it prevents the rank ligand from binding to rank receptor on osteoclasts. So, this would lead to the inhibition of osteoclast activity and bone resorption. This is basically bone physiology. You have to know this slide. This is very important. So osteoblasts and osteocytes, they express rank ligand, and this binds to rank. Whenever they bind to the rank receptor on osteoclasts, they activate osteoclasts. We have also the MCSF, which also activates. On the other side, we have the OPG, which is also secreted by osteoblasts. This OPG acts as a decoy receptor in order to bind to the rank ligand to prevent rank ligand from binding to the rank receptor on osteoclasts. By doing that, this would lead to less osteoclast activity. Okay, so once we have osteoclasts being activated, what happens? How does bone resorption happen? So first thing is attachment happens. So what happens is the osteoclasts attach to the bone by the AV-B3 integrins. So these are the AV-B3 integrins that helps in attachment. And this forms the sealing or the resorption zone. So this is basically the construction or the working area for the osteoclasts. What happens is that we have, or the osteoclasts have an enzyme that is called carbonic anhydrase. So What happens is that normally we have water and carbon dioxide. They join together to form carbonic acid, which is H2CO3. And by the action of the carbonic anhydrase 2 enzyme, it leads to the formation of hydrogen ions as well as bicarbonate. So this bicarbonate exits the cell, and we have chloride in return, and this chloride in return gets pumped. But let's talk now about the hydrogen ions. Once hydrogen ions are formed, they are pumped into the resorption pit by the hydrogen ATPase pump. And to maintain the electroneutrality, chloride is also pumped into the resorption pit. So now we have hydrogen chloride, which is acid. And you know, acid or acidic medium favors bone resorption and the dissolve, and it leads to the dissolve of the hydroxyapatite. So now we have acid in the resorption pit. So this would lead to the acidic environment would lead to the dissolving of the hydroxyapatite, which are the calcium and the phosphate crystals. Then we have also matrix degradation. Also, the osteoclasts secrete catechin K and MMP9 in order to degrade the organic bone matrix, which is the collagen. So by doing that, the degraded or the degradation products, they get removed from the resorption pit by transcytosis. So whenever, for example, we need calcium from our body, bone resorption happens, calcium gets transcytosed through the osteoclast and released through the blood. Moving on to calcium regulation. Since calcium should be tightly regulated, there are a lot of hormones and molecules that regulate the plasma calcium levels, starting with parathyroid hormone. And the parathyroid glands are composed of mainly the sheath cells, which are the source of parathyroid hormone. They are the ones responsible for secreting parathyroid hormone or the PTH. So these cells, they sense the extracellular ionized calcium. The ionized, the one that is free in the blood, that is not bound, through the calcium sensing receptor. So this is the calcium sensing receptor, and they sense the extracellular calcium levels. And we mentioned that the sheath cells are responsible for producing PTH. So whenever there is a lot of calcium or sufficient calcium, there is no need to produce PTH. So PTH gets degraded down. But the moment that calcium is not enough in the body, this would lead to a lot of reactions and the release of PTH. So if we have enough calcium, no PTH. Not enough calcium, there would be an increased PTH release. So PTH would be released into bloodstream to maintain the calcium levels, and this PTH binds to PTH1 receptors that are found in bone and kidney. So let's talk about the PTH effects on the bone. So we mentioned that PTH binds to the PTH1 receptor found in osteoblasts and osteocytes. So here's PTH that binds to PTH1 receptor, and this would lead to the stimulation of Frank L expression. This is important. So whenever you have a lot of Frank L expression, it means that more rank ligand will be able to bind to the rank receptor on the osteoclast. So as you can see, that rank L binds to the rank receptors on osteoclasts, and this would lead to osteoclast activation. So once osteoclasts are activated, bone resorption happens. And we mentioned once bone resorption happens, there is degradation of the hydroxyapatite. Then there would be the release of calcium into the circulation to maintain the calcium levels in blood. We have another effect of PTH on kidneys. We have effects on the thick ascending limb as well as the distal convoluted tubule. We mentioned that PTH binds to the PTH1 receptor, that they are highly expressed in the thick ascending limb. So what happens is that the PTH increases the paracellular reabsorption of calcium in kidney. And this is mediated by cyclic AMP. So what happens is that PTH binds to the PTH1 receptor. This would lead to the increased cyclic AMP, and this would favor the calcium reabsorption paracellularly. And as a result, there will be more reabsorption and reduced urinary calcium loss. We have another effect on the distal convoluted tubule. So also PTH binds to the PTH1 receptor. This would lead also to increased cyclic AMP activity, and this would lead to the expression of this channel, which is called the TRPV5. And this channel is found on the apical surface of the kidney, and this would lead to calcium entry inside the cell. Calcium would then bind to the calbindin, and it gets transported outside through two main transporters. We have the sodium calcium exchanger, which is also called NCX1, and we have the PMCA4, which is also called calcium ATPase. So overall, this process is requires ATP, and as a net effect, there would be increased calcium reabsorption into the blood. So to summarize, is that it would lead to expression of a lot of channels, and these channels would lead to the reabsorption of calcium as well as reduce the urinary calcium loss. Okay, so moving on to another hormone, which is calcitonin, and it also plays a role in calcium homeostasis. So calcitonin is secreted by the C cells, so C and C, which are called also parafollicular cells found in the thyroid gland. It basically counteracts the effects of parathyroid. So everything we mentioned about parathyroid, it literally counteracts those effects. So as an overall effect, it would lead to decreasing the plasma calcium and phosphate levels. How does it do that? It inhibits osteoclast differentiation. If we mentioned that osteoclasts, they come from macrophages or the monocytes. So if you decrease the differentiation, there would be less osteoclasts. Less osteoclasts means less bone resorption. So this wouldn't allow bone to get resorbed and the release of calcium. It also reduces osteoclast activity. So we mentioned that osteoclast plays a role in bone resorption, so it reduces this activity. So as a result, it would decrease plasma calcium levels and phosphate as well. It also decreases acid secretion by osteoclasts. So how does it do that? It alters the carbonic anhydrase enzyme. So we mentioned that this enzyme is really important for the production of hydrogen or hydrogen ions, and hydrogen ions are acidic. So by altering this enzyme, it would lead to the decreased acid secretion. Not only that, but it inhibits the hydrogen ATPase activity. And we mentioned that this channel pumps the hydrogen ions from the osteoclast into the resorption pit. By inhibiting this activity, it would lead to decreased acid secretion by osteoclast, and as a result, it would lead to reduced osteoclast activity. So the final result would be decreased bone resorption. And it also has effects on kidneys. So what happens is that it inhibits the renal tubular calcium reabsorption. We mentioned that PTH favors reabsorption, but calcitonin does the way opposite. It inhibits. So this leads to increased urinary calcium excretion. Moving on to another molecule that plays a role in bone physiology and regulating calcium levels. So we have vitamin D. Okay, so what are the sources of vitamin D? We can have it in our skin, or we could have it from our diet. So what happens is that UV light converts the vitamin D found in our skin, which is the 7 dehydrocholesterol, and converts it to cholecalciferol, which is the vitamin D3. So UV light converts the vitamin D in our skin, which is called the 7-dehydrocholesterol, into cholecalciferol, which is also vitamin D3. Or we can get vitamin D from our diet, which could be in the form of cholecalciferol and ergocalciferol. Okay? This is the first thing. Those two, vitamin D3 and vitamin D2, they go to the liver and they undergo the first hydroxylation. So hydroxylation happens at the carbon 25. So what happens is that these get converted to 25 hydroxy vitamin D. It is not the active form, but it is the major circulating and storage form of vitamin D. Then in the kidney, we have the second hydroxylation. So what happens is that there is an enzyme, which is called 1-alpha hydroxylase enzyme, that converts the 25 hydroxy vitamin D into a more active form, which is called the 1,25 dihydroxy vitamin D. This is the hormonally active form, and it is called also calcitrol. Okay? So what happens is that this active form is the vitamin that plays role in regulating calcium levels as well as phosphate levels. So what happens is that whenever PTH is increased or there is decreased calcium, what happens is that we need more vitamin D. So vitamin D, to cut it short, it plays the same role as PTH. It wants to increase calcium and phosphate in our body. Okay? So what happens is that whenever there's decreased calcium, we need more vitamin D. So in order to get the more active form of vitamin D, we increase the 1-alpha hydroxylase enzyme. And we mentioned that this enzyme converts the vitamin D into the active form. So there would be increased calcitriol. Okay? And whenever there's increased plasma calcium, so we don't need further more calcium. So what happens is that there would be decreased activity of the 1-alpha hydroxylase enzyme, and there would be increased activity of 24 hydroxylase enzyme. So what happens, or what does the 24 alpha hydroxylase, 24 hydroxylase enzyme do? It converts the vitamin D into an inactive form because we already have calcium in our body. So there's no need to convert calcium, vitamin D into the more active form. Instead, we convert it into the inactive form. And this is done by the 24 hydroxylase enzyme. So this leads to the formation of 24, 25 dihydroxy vitamin D. Okay, so what are the overall effects of vitamin D? We mentioned that it is similar to PTH, but PTH, it has a faster response, but vitamin D has a longer response. So what is the primary function of vitamin D? It maintains the normal plasma calcium concentration, and it has a lot of effects. It affects the intestines, which is the most important effect of vitamin D. It affects the bones, it affects the renal, it affects the endocrine. So starting with the intestinal effects, which is the most important mechanism of vitamin D function. So it leads to increased dietary calcium absorption. We mentioned that vitamin D likes to increase calcium. So what happens is that it favors the absorption of calcium through diet. And it is actually the main contributor to increased plasma calcium levels. Then we have bone effects, which will increase bone turnover, both resorption and formation. And whenever there's bone resorption, there's production or release of calcium and phosphate. And whenever the intestinal absorption is insufficient, vitamin D acts with PTH to mobilize calcium from the bone stores by bone resorption. Then we have also renal effects. It's similar to PTH. It increases the renal calcium reabsorption and decreases the urinary calcium loss. And also it plays an endocrine feedback. Whenever there's a high calcium, خلاص, we don't need more calcium. It decreases PTH synthesis by the parathyroid gland. So let's talk about the mechanism of vitamin D action on targeted organs, starting with the intestinal calcium transport. So what happens is that the active form of vitamin D3 or vitamin D binds to vitamin D receptors in the enterocytes, especially in the jejunum and the ileum. So what happens is that this would lead to the expression of the TRPV6 apical calcium channel, as well as the calbindin D9K, as well as the expression of tight junction proteins to allow for paracellular calcium diffusion. So let me repeat. So vitamin D, the active form binds to VDR. This leads to expression of channels and co-transporters in order to favor calcium absorption. So what happens is that more tight junction proteins are available. This favors the calcium diffusion paracellularly. Then we have the TRPV6 apical channel in which the calcium enters through and binds to calbindin D9K and exits the enterocyte through the blood, into the blood by the PMCA1B. Okay? This is the most important function of vitamin D, acting on the intestine, specifically the jejunum and the ileum. Moving on to bone remodeling, we mentioned that it has an effect on the bone. So the active form of vitamin D acts on osteoblasts and osteocytes, but mainly osteoblasts. So what happens is that this would lead to an increased rank L and a decreased OPG ratio. So it favors osteoclast differentiation and activation. And whenever we have osteoclast activation and differentiation, this would lead to an increased bone resorption to release calcium when needed. Then we have the action on the kidneys. So what happens is that the active form of vitamin D increases the expression of proteins, channels, binders in order to favor calcium reabsorption. So what happens is that it increases the expression of the TRPV5 channel. This would lead to calcium entry through it. Then it would also increase the expression of the calbindin D28K. This is an intracellular transport protein that transports calcium into the basolateral transport channel, which is the PMC A1B, and also the sodium calcium transporter. And as a result, it would lead to increased reabsorption, and the calcium would be released into the blood. Okay, so we talked a lot about calcium. Now moving on to phosphate. So phosphate also needs to be regulated in our body. And phosphate has a lot of important functions. It is essential for skeletal integrity. We mentioned that hydroxyapatite includes the calcium as well as phosphate. Phosphate is required for ATP production and as well as nucleic acid synthesis, and it acts as a substrate for kinase and phosphatase reactions. Moving on to body distribution, we mentioned that mostly they are stored in bone as hydroxyapatite, and 20% of the phosphate is distributed in soft tissues and extracellular fluid. So, how can we maintain phosphate? Phosphate can be maintained by different organs. It can be maintained by intestine, either favoring absorption or not. In the kidneys, phosphate can be reabsorbed or excreted depending on the signaling molecule, as well as bone. Phosphate storage happens there, and there is also endocrine signaling, whether we need phosphate or not. And phosphate homeostasis is controlled by different molecules. This includes vitamin D. An important molecule is the FGF23, as well as the PTH as a secondary role. So let's talk about the intestinal phosphate absorption. What happens is that phosphate can be absorbed in an active transport, meaning requiring energy, or a passive paracellular transport. Let's start with the active transport. And this happens transcellularly. So what happens is that we have the sodium phosphate 2B co-transporter. It takes a sodium as well as phosphate. It requires, of course, energy. And this transporter or co-transporter is upregulated by vitamin D, the active form. So vitamin D favors calcium absorption as well as phosphate absorption. Okay. And this is a transcellular process. This is an active process that requires energy. Then we have the passive PP, passive paracellular transport, and it is diffusion driven. So whenever we eat more dietary phosphate, it leads to more diffusion and more absorption of phosphate. All right. So let's look at the renal phosphate reabsorption, and this happens in the proximal tubule in the kidney. So what happens is that reabsorption of phosphate happens, and it is done by three main channels. We have the sodium phosphate 2A and the sodium phosphate 2C, as well as the PIT2. All of these channels, they reabsorb phosphate, then the phosphate exits through the XPR1 transporter. And you have to remember this because we're going to talk about them when we talk about the FGF23 right now. Okay, FGF23. What is FGF23? It's a bone-derived phosphaturic hormone. So the main important role of this molecule is to maintain phosphate levels. So it primarily regulates serum phosphate as well as vitamin D levels. It is synthesized by the osteocytes as well as the osteoblasts, and it acts by binding to the FGFR1 or the FGF receptors. And another essential co-receptor is the clotho. So clotho expression confers to tissue specificity. So they are found mainly in the kidney as well as the parathyroid. So FGF23 plays a major role on kidneys and parathyroid glands, and we're going to talk about it. Okay. So what are the kidney effects or the what are the effects of FG23 on the kidneys? What happens is that when we mentioned the phosphate reabsorption, we talked about the sodium phosphate 2A and 2C, and they play a role in reabsorbing the phosphate. What happens is that FGF23, it wants to decrease phosphate in our body. So FGF23 binds to the FGF receptor with the help of the coprotein, and this leads to an increased activity of the MAPK. Once MAPK increases, it decreases the expression of sodium phosphate 2A and 2C. Okay, so if there's a decreased expression of this, it would lead to decreased reabsorption of phosphate. So what happens is that there's decreased proximal tubular phosphate reabsorption, and if there's decreased reabsorption, there would be increased urinary phosphate excretion. So there would be phosphaturia. And as a result, there would be decreased plasma phosphate level. So what we want you to know is that FGF23 plays a major role in decreasing phosphate levels in our blood. FGF23 plays also a role in vitamin D. What happens is that it wants to decrease vitamin D. So how can someone decrease vitamin D? It could decrease the 1 alpha hydroxylase enzyme. And we mentioned that this enzyme is important in in activating or forming the active form of vitamin D. So if you decrease this, you would lead to decreased active form of vitamin D. Or you can increase the 24 hydroxylase activity. So by doing that, you're converting vitamin D into the more inactive form in order to decrease the vitamin D effect. So as a result, there would be decreased synthesis of the active form of vitamin D, which is this 125 dihydroxy vitamin D. So as a consequence, if there's overall decreased vitamin D, there would be decreased intestinal phosphate absorption. We mentioned that vitamin D plays a role in phosphate and calcium absorption. So there would be decreased intestinal phosphate absorption, there would be decreased intestinal calcium absorption as a secondary effect, and as a result, there would be prevention of hyperphosphatemia. And there's also a physiological feedback loop. So whenever D, the active form, is high, it leads to the increased production of FGF23. Why? Because calcium raises, vitamin D raises calcium and phosphate levels. So in order to prevent the high raise of those molecules, it leads to the production of FGF23. And what are the effects of FGF23? It leads to decreased calcium or mainly phosphate than calcium levels. So what happens is that the FGF23 also does a negative feedback by decreasing the vitamin D levels, the active form. Okay, so FGF23 also has effect on the parathyroid glands, since also parathyroid plays a role in increasing phosphate as well as calcium levels. So what happens is that the FGF23 suppresses the PTH gene expression and also decreases the PTH secretion. And this effect is closely dependent, as we mentioned. So whenever we have decreased PTH, there would be decreased calcium and phosphate mainly. So the FGF23 prevents the excessive PTH mediated. So as a result, it would decrease bone resorption as well as phosphate wasting. And the overall effect of FGF23 is to help fine-tune the mineral balance in our body. So to summarize, the role of FGF23, it decreases renal phosphate reabsorption. So phosphate would get excreted. It would decrease the formation of the active form of vitamin D molecule, and it would also decrease the PTH secretion. So as an overall effect, it protects against hyperphosphatemia. It also maintains phosphate balance during high dietary phosphate. Whenever you're taking a lot of phosphate, this would lead to the production of FGF23 in order to prevent or to maintain the phosphate levels during high dietary intake of phosphate. Also, whenever there is an increased vitamin D activity, the FGF23 is like a brake. It stops the vitamin D activity, it counteracts it. And just to know, this is the FGF23, this is the FGFR receptor, along with the clotho, which is the essential co-receptor. Okay, so we have other hormones that play a role in bone remodeling, especially the sex steroid hormones, and especially the estrogen. So estrogen has a protective effect against osteoporosis. Why does that happen? Because estrogen, it decreases the osteoclast formation. So, you know that bone remodeling is a balance between bone formation and bone resorption. So, if there's decreased osteoclast formation by estrogen, also estrogen plays a role in increasing the apoptosis of osteoclast progenitors and mature osteoclasts. So, overall effect, it decreases the osteoclast. So, there would be decreased bone resorption and an increased bone formation. So, estrogen has a protective role in preventing bone diseases like osteoporosis, and it does that by slowing down bone resorption and overall bone turnover. Then we have also estrogen plays a role along with androgen in decreasing the apoptosis of osteoblasts and osteocytes. So if you're increasing the apoptosis of osteoclasts and decreasing the apoptosis of osteoblasts and osteocytes, you are favoring bone remodeling to the bone formation aspect, not from the bone resorption aspect. So that's why it preserves bone formation and it also preserves the bone microarchitecture. But what happens is that with age, there's age-related bone loss. This happens in both men and women, and it is basically a gradual decline in bone mass with aging, especially in postmenopausal bone loss. Because in menopause, what happens is there's sudden estrogen deficiency in the woman. And we mentioned all the protective effects of estrogen for the woman. So if there's no estrogen or very low sudden estrogen, it would lead to an increased osteoclast lifespan and an increased osteoclast activity. And we mentioned that the osteoclasts are the killer osteoclasts. They like to eat the bone so much. So in menopause, there is loss of estrogen's pro-apoptotic effect. This would lead to more osteoclasts surviving and favoring of bone resorption. Okay, so the result would be accelerated bone resorption. So why are men less affected? Because they don't have the sudden estrogen withdrawal like women during menopause, as well as they have a more gradual hormonal decline. So their androgens are still stable. They decline very, very slowly. And that's why they are less affected. So as you can see from this graph, is that during menopause, there is a sudden decline in bone loss because of the killer osteoclasts and the favoring of bone resorption. On the other hand, it's for the males, they don't have the sudden estrogen withdrawal. So they have a gradual decline because also their hormones gradually decline, not like the women in which sudden drop of estrogen could lead to bone loss or decreased bone mass. Then glucocorticoids have effect on also bone remodeling. So in general, the effects of glucocorticoids, they favor bone resorption. And whenever there's bone resorption, there is an increased calcium in our body. So as a result, there would be decreased intestinal calcium absorption. And also because we have a lot of calcium in our body, it would lead to increased renal calcium loss as a secondary parathyroidism, sorry. So the most critical effect is the inhibition of osteoblasts for differentiation. So what happens is that the osteoblasts are not differentiated. So, and we mentioned that the osteoblasts play a role in bone formation. So if they're not differentiated well, there would be decreased bone formation and an increased osteoblast and osteocyte apoptosis. So that's why there's always a balance between bone formation and bone resorption. If the bone formation decreases, it favors bone resorption. If bone resorption decreases, it favors bone formation. So it's a balance between the two entities. So as a clinical consequence, we have glucocorticoid-induced osteoporosis. So what happens is that there's increased fracture risk, even with normal bone mass density. All right. So, moving on to bone turnover and biochemical markers. So, what happens in bone turnover is a continuous process of bone resorption, which is mediated by the osteoclast, and bone formation, which is mediated by osteoblast. So, what happens is that during bone resorption, the osteoclast is breaking down bone. So, there is mineral dissolution as well as degradation of bone matrix. And all of these get released along with the collagen breakdown products into the blood and urine. And it is very important, or clinically, we could use them to detect the bone turnover markers in order to assess the bone remodeling rate. So if we find more bone formation markers, it means that we're favoring bone formation. If we find that there's more bone resorption markers, we're favoring bone resorption. So it helps us detect the bone remodeling rate, as well as it helps us monitor the response to anti-resorptive therapy. So if we give someone an anti-resorptive therapy, it means that there would be decreased bone resorption markers and increased bone formation markers. It also helps us evaluate inter-individual treatment responses. So it helps us guide us which treatment is better than which treatment for each individual. Okay, so there we can classify bone markers into bone formation and bone resorption markers. I don't think you're required to know, but in case, quick mnemonic in order to answer the MCQs. So whenever you see an X, this indicates bone resorption because X, you want to break it. So CTX1 as well as the NTX1, they are bone resorption markers. Trap also is a bone resorption marker. If you want to trap someone, you want to, I don't know, you want to break that or you want to kill them. So trap is also considered a bone resorption marker. Then we have the bone formation markers. It includes the osteocalcin. It includes the bone alkaline phosphatase. And you have to remember that whenever the environment is alkaline, it favors bone formation. And whenever it's acidic, it favors bone resorption. So alkaline phosphatase is a sign of bone formation. Then we have the procollagens like the PINP and PICP. So if there's procollagen, it means there's work in progress. It means because collagen or procollagen is then converted to collagen, and collagen gets laid down in the new bone. So it's a sign of bone formation. Okay, so how can we assess bone density? So what is bone density or bone mineral density? It is the amount of mineral per unit area, measured in gram per centimeter squared. It is a major predictor of fracture risk. So, but it does not, yani, it identifies that there is bone loss, but it does not identify the cause of bone loss. So it mentions, yes, there's bone loss or there's osteoporosis, for example, but it does not identify the cause for that bone loss. So how can we measure bone density or bone mineral density? It is using the DEXA scan. It is the gold standard for measuring bone mineral density. And we use common sites like the lumbar spine, as well as the femoral neck, as well as the forearm. Then we assess, and then results appear. So these are the DEXA scores. So the T score is very important because it tells us whether it is a normal bone density or low bone mass or a diagnosis of osteoporosis. So you have to know these numbers. Whenever the number is greater than -1, it is considered normal. Whenever the number is between 1 to -2.5, it is called osteopenia or decreased bone mass. And this is a high risk towards developing osteoporosis. Once you have a number of -2.5 or less, then we can diagnose a patient having osteoporosis. Then we can add some Z scores in order to match the patient with the age and the sex. And the Z scores are also useful in children and young adults. Okay, final slide. We have some bone mineralization disorders and osteoporosis. So bone mineralization disorders happens because the bones do not get mineralized by the calcium and the phosphate or the hydroxyapatite crystals. So if it happens in children, it is called rickets, and it affects the growth plates. So children would come with bone pain, deformities, as well as growth failure. But if it happens in adults, it's called osteomalacia, and it affects the mature bones. So patient would come with diffuse bone pain as well as muscle weakness. Then moving on to osteoporosis. It is actually the most common bone disease. It is characterized by decreased bone mass. And what was the cutoff? It's negative 2.5 or less. So what happens is that there's deterioration of the microarchitecture. The bones become porous, they become brittle, easy to be breakable. So there's an increased fracture risk, as you can see here. And this is due to imbalance between the osteoclasts and the osteoblasts. So osteoclasts, they mediate resorption. There's an increased osteoclast mediated resorption, and osteoblast they mediate formation. So there's decreased osteoblast mediated formation. And that's all about bone physiology. All right, let's talk about thermoregulation. So, our body is divided into the core and the shell. The core is basically the internal regions. It includes the CNS structures like the brain, spinal cord, as well as the major organs like the liver, kidney, heart, and muscles. And they are the primary site of heat production. So, because they undergo a lot of processes and a lot of metabolism, they produce heat. And naturally, they are homeothermic, meaning that they can maintain a relatively constant temperature with minimal variation. And this is really important because a lot of enzymes they work under a specific temperature. So if the temperature is high, very high, or very low, they won't work. And if those enzymes and proteins are not working, this would lead to organ damage. So that's why they need to maintain a relatively constant temperature with minimal variation. And how does the heat transfer? It moves from the core to the skin by the blood circulation. Then moving on to the shell, which includes the peripheral regions. It includes the skin, the subcutaneous tissue, as well as the fat. And what is the function of the shell? It acts as an insulator to stabilize the core. So in order to prevent heat, for example, loss or a lot of heat going to the core, it acts as an insulator to stabilize the temperature of the core. And fat is specifically important because it slows heat transfer. It acts as a good insulator in order to prevent any heat loss coming from the core or any extra heat that is going to the core in order to maintain the temperature. So in nature, the shell is poikilothermic. It means that temperature fluctuates based on the surrounding environment. If the surrounding environment is cold, the shell would be cold. If the surrounding environment is hot, the shell would be warm. So, what are the sources of heat in the body? It could be divided as into internal sources or external sources. And for internal sources, they are basically divided into shivering thermogenesis or non-shivering thermogenesis. So, from its name, shivering thermogenesis, it means that heat is produced by contractions or shivering, contractions and relaxations of the skeletal muscles due to activations of bunch of neurons by the posterior hypothalamus. Then we come to the non-shivering thermoregulation. It means that non-shivering thermogenesis. It means that heat is produced, but not related to skeletal muscle activity. Example, brown adipose tissue, it produces heat through the electron transport chain without the need to shiver. So, what are the examples of are example of sources of heat that are internal? We could say that basal metabolism is considered an internal source of heat because just you sitting doing nothing, the organs are still functioning. Like you breathe, the heart is pumping, you're breathing. So a lot of functions are happening in your body, even if you're not doing anything. So this is basically the basal metabolic rate. So metabolic rate would lead to the production of heat as a side product. So we have also food-induced thermogenesis, which basically whenever you ingest food, there would be production of heat. Also, physical exercise would lead to shivering, thermogenesis, and the production of heat from our inside our body. Then we have the external source of heat, which includes the ingestion of hot food. If you're ingesting something hot, then this heat gets transferred to your body. Also, Ventilation, which includes the hot climate. If the surrounding environment is hot, then it would emit heat and you would feel warm. Also, radiation. So, short waves coming from the sun or long waves coming from the surrounding also emit heat, and it is considered an external source of heat. So let's talk about the mechanism of heat loss. Mechanism of heat loss could be divided into radiation, evaporation, conduction, and convection. But the most common cause of heat loss from our body is through radiation, which basically there's loss of heat from our body without any physical contact. So normally any heated object releases heat in the form of radiation. And since we produce heat from our body inside, we emit or radiate this heat. And this is actually the most common mechanism of heat loss. It accounts to 60% of heat loss. Then moving on to evaporation. And this is especially important when sweating. So the sweating itself doesn't cause heat loss, but the evaporation of this fluid or evaporation of the sweat itself is what causes heat loss. So basically, evaporation is the loss of energy from the skin and respiratory tract due to water evaporation. Okay. And it depends highly on the humidity of the air. So if the air is humid, then the mechanism of evaporation wouldn't be that successful. So you wouldn't lose heat easily. Especially, for example, if you're in Jeddah, for example, it's a very humid city. So even if you were sweating because of the weather there, you wouldn't feel cold after sweating because the sweat is not evaporating because the surrounding environment is humid. But here in Riyadh, because it is very dry, so the sweating mechanism or the evaporation mechanism is really helpful in losing heat. Then comes the conduction, which is basically lose the loss of heat by the transfer of thermal energy from someone through the direct contact with the surroundings. So if you're sitting on the table or the desk, if you're touching an object, so you lose heat through conduction. Finally, convection is similar to conduction, but with the help of air currents. So it's basically the loss of heat depending on the current of the air. For example, in a windy area, you lose heat easily because heat gets transferred by the air. For example, if you're feeling hot, you open the AC or the fan, and the fan basically emits air to take the heat from the body through convection. Okay, so thermoregulation in newborns. Newborns, because they are immature, they are still developing, they have an immature nervous system, limited muscles, limited fat. So they are vulnerable to hypothermia as well as hyperthermia. So what are the reasons that make them vulnerable to hypothermia? It's because their skin is wet, and whenever there's wet skin, it makes it easier for them or for the skin to for the water in the skin to evaporate. So there's an increased heat loss from the body due to the evaporation of the water from the wet skin. And they also have a high metabolic rate in relation to their body size. So they are small in size, but they have a high metabolic rate. So since they have high metabolic rate, they would emit or they would lose energy faster than normal. And they have limited ability to generate heat through muscle contraction. We mentioned that their muscles are still immature, so they don't really have the shivering mechanism. So they have a limited ability to generate heat. They have poor thermal insulation by adipose tissue, although they have brown adipose tissue, but they don't have enough, like for example, the other type of adipose, which is the white adipose tissue. They also have limited behavior thermoregulation. They cannot say they're cold, for example, or they're hot, they cannot take a blanket, for example, and cover themselves. That's why they have limited behavior. They also have the immaturity of the hypothalamic thermostat. So their hypothalamus is the organ that controls thermoregulation or the heat regulation. So they are mature. So that's why they are vulnerable to hypothermia. And one thing to notice is that the only source or the most important mechanism of thermoregulation is the non-shivering thermogenesis by their brown fat. It is the primary source of heat. Although the stores of the fat is limited, this would make them more prone to hypothermia because these brown stores may get exhausted. So what makes them vulnerable to hyperthermia? They have immature sweating mechanism. They can't. They still have immature sweating glands. So that's why they have poor nervous supply to the sweat glands. That's why it makes it makes them immature for sweating mechanism. Um, and if hyperthermia happens, this would lead to hyperventilation, and hyperventilation would lead to loss of moisture. So they are at risk of dehydration. So we mentioned that the brown fat is the most important source of thermogenesis in children or in babies. So where is brown fat located is around the blood vessels, in the neck, in the upper back, in the axilla, around the kidneys, a lot of places. And what makes it brown? Because it has a high density of mitochondria. That's why they look brown in color. And they act as the electronic blanket for the baby. So, how do brown fat produce heat? So, under cold stress, there will be increased secretion of TSH as well as adrenaline. These are very important in causing non-shivering thermogenesis. So, TSH would lead to increased thyroxine, then thyroid would be converted to more active form of thyroid hormone. And all of these would generate heat by increasing the uncoupling of the electron transport chain from ATP and the generation of heat through the mitochondria. Okay, so we have an integrated system of control that plays role in regulating the temperature in our body. But as in any system, we have receptors, we have control centers, and we have the effectors. Starting with the receptors, which are the sensors, it could be divided into the peripheral and the central. The peripheral thermoreceptors, they are found in the skin. We have cold and warm thermoreceptors, and they basically sense the temperature and provide a feed forward control to the central receptors in the internal organs as well as in the hypothalamus. So we have also central thermoreceptors that are found in inner organs, like the hypothalamus, and they provide the feedback control and they relay the message to the control system, center. The control center is basically the hypothalamus. It's basically the master organ that controls a lot of things. One of the things it controls is the temperature. So the hypothalamus could be divided into the anterior and the posterior hypothalamus. The anterior hypothalamus is basically the area that contains the central chemoreceptors as well as the thermoreceptors, and it is basically the primary integrated which has the set point. So it decides I want the temperature to be 37.5, for example. I want the temperature to be 38. So the anterior hypothalamus is where the thermostat is and where the set point gets decided. Then we have the posterior hypothalamus. And in this area, it includes the heat losing and the heat promoting centers. So basically, whenever, for example, someone wants to shiver, or for example, someone wants to sweat, the posterior hypothalamus is the controlling area, and it receives inputs from the central and peripheral chemoreceptors and then activate the effector mechanism. So what are the effector mechanism? Depending on the response. So if someone is feeling cold, obviously you need to decrease the heat loss and to increase the heat production. So how can we decrease heat loss? We decrease heat loss by activating the sympathetic nervous system done by the posterior hypothalamus. This would lead to vasoconstriction of the blood vessels. And whenever vasoconstriction happens, it prevents the heat from getting lost through the skin. And it shifts the blood towards the vitally or the important vital organs. So this would lead to decreased heat loss. Then we also have piloerection by the alpha 1 neurons. And whenever piloerection happens, like it's basically called goosebumps. So this adds an extra insulated layer to prevent heat loss. And we have also behavioral response. So whenever you're feeling cold, you try to wear warm clothes, you try to curl up to reduce the surface area, you get a blanket, etc. Now, how can we increase the heat production? So we can increase the heat production by increasing the muscular tone and the voluntary activity, doing, for example, physical exercise, walking, also the shivering mechanism, which basically also controlled by the posterior hypothalamus. Also, we have the chemical thermogenesis. This happens by increasing the secretion of adrenaline as well as the TRH, TSH, and thyroid hormones. And we have also the non-shivering thermogenesis done by the brown fat using the beta 3 receptors. Then, moving on to effective response to heat. When you are warm, you want an increased heat loss. How can we increase heat loss? By inhibiting the sympathetic nervous system. So, what happens when you inhibit the sympathetic nervous system? You have vasodilation. So, vasodilation would increase the surface area or the surface area for heat loss in the skin. So, this would lead to heat loss. Also, you activate the cholinergic fibers of the sweat glands. So this would lead to sweating, and sweating with evaporation would lead to heat loss. We have also a behavioral response, so wearing lighter clothes, turning on the AC, for example, or something. Then we want to decrease the heat production. How can we decrease the heat production? We decrease the muscle tone activity. So instead of moving around, you just stay calm. You decrease the food appetite because food causes the food-induced thermogenesis. Also, there's decreased secretion of adrenaline as well as thyroid hormone. So this would overall decrease the chemical thermogenesis. One thing to notice is that the sweat glands, they are innervated by the sympathetic nervous system, and it could be cholinergic as well as adrenergic. But what we want to focus on is that the sweat glands that are responsible for thermoregulation, they are innervated by the cholinergic, especially the M3 acetylcholine receptors, and they are the eccrine sweat glands. So the glands that are responsible for thermoregulation are the eccrine glands, and they are innervated by the sympathetic cholinergic nerve fibers, and they have the M3 acetylcholine receptors. It's really important because we have other sweat glands like the apocrine sweat glands. They are involved in emotional sweating as well as in physical exercise, and they are innervated by the adrenergic nerve fibers. So they have the adrenergic receptors alpha and beta. Okay, now let's talk about fever. So, whenever you have an infection, microbial toxins, mediators of inflammation, immune reactions, this would lead to the monocytes, macrophages, and cells, other cells to release pyrogenic cytokines. The pyrogenic cytokines are interleukin 1, interleukin 6, alpha, interferon gamma, for example. These are pyrogenic cytokines, and these go into the circulation as well as the microbial toxins. And the hypothalamus doesn't have a blood-brain barrier, so they can detect what's circulating through the blood. So, when these toxins and cytokines go through the hypothalamic endothelium, it senses that. And this would lead the production of prostaglandins, especially prostaglandin E2. It's really important that prostaglandins are the ones responsible for increasing the set point, the temperature set point. So what happens is that there's an increase of prostaglandin production, especially PGE2. Okay, this would lead to the increased activity of cyclic AMP, and this would lead to the sensitization of the thermoregulatory set point. This would lead to an elevated thermoregulatory set point, and that's how you get fever. Okay, so let's recap. So fever basically happens because there's an increased temperature set point. So instead of the normal 37.5 fever, the set point changes, for example, to 39 degrees Celsius. And this is done as a physiological mechanism. How does it happen? We mentioned that bacterial infection, inflammation would lead to the release of endogenous spirogen cytokines and signals from the macrophages and monocytes, and this would get through the hypothalamic endothelium, and there would be release of prostaglandins in the hypothalamus. Okay, prostaglandins, they modulate the sensitivity of thermal receptors in the hypothalamus, and they raise the set point. So what happens here is that you get the toxins and prostaglandin, especially prostaglandin E2 production happens. So this would lead to a set point suddenly raised to a high value. So instead of the normal 37.5, for example, the set point is 39 right now. So although your body temperature right now is normal, but in fever, it's considered not normal. Even if you're 37.5 right now, your body perceives that no, you're way below the set point, the new set point, which is 39. So the body perceives that you are cold because 39 is the set point and you are 37.5. So it perceives that you are 1.5 degrees less than the normal set point. So it perceives itself as being cold. So what happens when you're cold? Vasoconstriction happens in order to decrease heat loss. Piloerection also happens. Epinephrine secretion, shivering happens. So this what happens during the rising phase of the of fever. You get chills. You feel cold, although maybe your temperature is normal, but the new set point has made it that the body perceive itself as feeling cold. That's why you get chills. And after a while, when the temperature resolves down, the bacteria resolves and everything goes back, a crisis happens. So what happens is the set point suddenly goes back to the normal. And originally, you had the body temperature of 39, but now the set point is 37.5. So what happens is that the body perceives that you have a high body temperature and it needs to drop it down to the normal back to the normal. So what happens is that the mechanism of vasodilation as well as sweating increases. And that's why it is the resolving phase of the fever. This is very important because a lot of MCQs can be asked about this graph. So the resolution phase of fever is that vasodilation happens and sweating happens in order to return back to the original temperature. And that's basically it. So a way to remember is that whenever people say, "Oh, you're sweating and you're sick," it's a good sign because your fever is resolving and you're returning back to the normal physiological state. Okay, another condition which is malignant hyperthermia that is important to talk about. So what happens is that there's a defect in the ryanodine receptor in skeletal muscles. And this ryanodine receptor is connected to the sarcoplasmic reticulum, and you know that the sarcoplasmic reticulum it stores a lot of calcium. So what happens during surgeries, whenever we give, for example, if a patient has a defect in the ryanodine channel receptor, um, and we give anesthetics like halothane or muscle relaxants like the succinylcholine, it leads to uh, opening or activating this channel. So as a result, there would be increased release of calcium into the myoplasm. And you know, calcium is an ion that excites everything. So that there would be a lot of prolonged muscle contraction that even would lead to rigidity. And what happens is that when calcium is released, there would be an increased metabolic rate along with oxygen consumption. There would be increased heat production in skeletal muscles because of the contraction and heat production. And this would result in a dangerously high core body temperature, as well as tachycardia, hyperventilation, and acidosis. And it's an emergency, especially during surgeries. So, in order to prevent that, we give dantrolene, which is a ryanodine receptor blocker. So, what happens is that they block the ryanodine receptor in order to prevent the succinylcholine as well as the halothane from activating this channel and the release of calcium that would lead to muscle contraction, heat production, body temperature rising, tachycardia, hyperventilation, and acidosis. And that's basically it. So moving on to LGDs and starting with fractures. So a fracture is basically a broken bone plus soft tissue injury. So we cannot forget about the soft tissue that surrounds the bone, things like muscles, nerves, blood supply. So whenever you suspect a broken bone, you also suspect soft tissue injury. So, MSK trauma could be divided into an open trauma or a closed trauma. And the open trauma is associated with high energy trauma. So, things like motor vehicle accident or falling from a large height. This would lead to the bone breaching the skin, and the skin would basically be open to the surrounding, to the environment. So this increases the risk of infection as well as vascular damage. Then we have the closed trauma, in which the skin is still intact, but you could have extensive soft tissue injury as well as fractures. So we can divide MSK trauma into fractures, which means breaking the bones. We can divide it into dislocations, which mean that there's displacement of the bone from its original location. And we can have both, in which there's fracture and dislocation. And usually this requires a lot of energy because not only you're breaking the bone, but you're displacing it from its normal position. So this is a closed trauma. You can see that the skin is still intact. There are no openings, but you can find extensive soft tissue injury, and on imaging, you can find fractures or dislocations too. This is an open wound or an open trauma. As you can see that the bone breached the skin, leading to openings. You can see how there's vascular damage as well as swelling. So it increases the risk of bacterial infection. So we have to make sure that we maintain proper wound care. And the most important step in management is antibiotic administration, since this open trauma is a door for bacteria to invade. Okay, so here you can see this is a proximal humerus fracture. It is actually very common in MSK traumas, but the joint itself or the glenohumeral joint is not displaced. There's only just fracture. On the other side, you can see no fractures at all, but the bone is dislocated. So the glenohumeral joint is dislocated. So this is fracture and this is dislocation. But we could also have fracture and dislocation. So you could see here there's a fracture of the humeral head. Not only that, but there's also dislocation of the glenohumeral joint. You can see the joint is dislocated. And here is an image of the bone reduced back to its normal location, but still you can see that there's a fracture right here. Okay, so we can classify fractures according to their morphology. So transverse fractures are basically horizontal lines or horizontal breaks in the bone. Then we have the linear, in which the lines align parallel to the bone axis. Then we have oblique, in which the fractures occur at an angle. It could be non-displaced or displaced. So non-displaced, it means that the bones are still aligning together. In oblique displaced, the bones or the shafts are shifting. They're not aligned together. Then we have the spiral, but someone can tell me it looks like the oblique. It's actually, yeah, but that's only what you can see, because in spiral, the fracture extends way more than what can be seen. So usually spiral fractures indicate a twisting or torsion injury. Then we have a green stick injury, which is very common in children, in which the joint is bent and cracks happen. But it's not actually a fracture, complete fracture, but just cracks from the bending of the joint. Then we have the comminuted, which is actually the most dangerous or the most extensive fracture according to morphology. You can see how the bones are shattered into pieces. It is usually indicates a direct trauma, direct higher energy trauma. It is associated with a lot of nerve injuries as well as blood injuries. So it's associated with soft tissue injuries. So you could have muscle problems, you could have nerve problems as well as vasculature problems. And it is the most difficult to deal with actually. Okay. So we can also classify MSK traumas according to their anatomical location. So we can have spine trauma, things that affect the vertebral column as well as the spinal cord. And whenever you have spine trauma, you have to assess the nerves if they are still functional or not, because depending on that, treatment differs. You can just have a small minor fracture in the spine, but the nerves are still intact. But other conditions, you can have a lot of fractures in the spine as well as the nerves are damaged, so it needs more intervention. Then we have upper limb trauma, and we talked about the proximal head fracture. There's also some displacement right here. Doctor wanted to show you guys the epiphyseal plate growth or the growth plate. It sometimes get mixed up with a fracture, but don't worry about it. The doctor won't bring it at all because it's confusing also to residents and yeah. So we also have a mid-clavicle fracture that led to displacement. And you can see how the clavicle is displaced upward, and this causes a lot of pain for the patients. Then moving on to the arm, forearm, and the elbow. So you can see here that there's a midshaft humeral fracture, and you can see how it's comminuted because there are parts or pieces of bones that are broken down and shattered. We can also have fractures around the elbow. Here there is dislocated elbow, and on reconstructive imaging, you can see there are also fractures. So it's fracture dislocation. In the forearm, you can see how the radius and ulna are fractured. And here you can see the most common fracture in elderly, which is the distal radial fracture. You can see how the distal radius is fractured on X-ray. Then moving on to lower limb, actually, it is very common, especially with elderly as well as chemo patients. It could affect the femoral neck fracture. It could affect the acetabular fracture. There could be also, for example, here an oblique fracture of the femoral shaft. We could have different presentations in the lower limb. And you could see also here there's a patellar fracture. You could see there's a tibial fracture. The proximal tibial fracture. You can see also here there are signs of tibial shaft fracture as well as also fibular fracture. You can see also here ankle fracture as well as dislocation, and you can see how they are treating it using pins and needles and different surgical approaches. Okay, so moving on to management. What the doctor wants you to know is that there are different types of management, and management depends on the how extensive the trauma is. So some can be dealt with non-surgical, which means immobilization, and these include the sling, telling the patient to do non-weight bearing things, applying a cast. These are all non-surgical and help in stabilizing the broken bone without moving it that much. Then we have some surgical techniques. This includes the CRPP, which is closed reduction percutaneous spinning. Then we have the ORIF, which is open reduction and internal fixation. And we have the external fixator or external fixation. You can see some example here is like a cast, as well as here. This is external fixator. These are open reduction and internal fixation. So you don't need to dive into details, but what you need to know is depending on the etiology or depending on how severe it is, we could treat fractures with non-surgical management, including the sling and the non-weight bearing as well as the cast, or we could have some surgical options in case the non-surgical options didn't work. All right, bone pain. So in general, if you have any pain, you need to have detailed history and physical exam. And this allows us to know more about the pain or about the chief complaint. So in history, you ask for the site, the onset, the character radiation, etc., in order to form differentials and know more about the chief complaint. Then we do some physical examination to assess this pain, and we check for movement, we check for a lot of things, if there are signs of inflammation, in order to reach closer to our probable diagnosis. And from history and physical examination, we need to know if it's actually bone pain or other tissue pain. It might be bone pain, it might be joint pain, it might be muscle or tendon or ligaments. So, with history and physical examination, as well as imaging to confirm diagnosis, we can be 100% sure that if it's a bone pain or not, or any type of other tissue pain. Okay, so let's start with a patient who was admitted to the ER with a shoulder pain. Now, how can we confirm this or confirm the diagnosis that this pain is caused due to trauma. So based on history and physical examination and imaging, you can understand more about the shear complaint. So he would tell you, for example, that I was walking and I fell on my shoulder. It happened suddenly. So what's the diagnosis? Most probably the MSK pain or the bone pain is caused by trauma. And during physical examination, there might be limited movement, there might be signs of swelling, deformities. So after doing our physical, you go with imaging and you can see there's a proximal humerus fracture. So moving on to another patient who has comorbidities like diabetes, immunocompromised, that complains of bone pain also. And I need to know what's the underlying cause of bone pain because based on that, you manage. So he would tell you that he didn't have any trauma. This started gradually. And he would tell you that he has diabetes, he's immunocompromised. For example, he had a wound infection or something. So based on that and based on physical examination, you look for example, pus in this area, as well any signs of redness, hotness, swelling, pain. Then we confirm using our imaging. And in imaging, you can see how there's bone destruction. And most probably it's an infectious cause based on history, physical exam, and imaging. So it's osteomyelitis. Okay, so moving on to MSK pain due to rheumatoid arthritis. So a patient would come telling you, for example, he has morning stiffness. The pain is worse at the morning, improves with movement. He might have a lot of other things affecting his body other than just the joints because the rheumatoid arthritis is a systemic disease. So based on history, based on physical examination as well, and based on imaging, you can see how the deformities of rheumatoid arthritis appear. So the MSK pain or the bone pain is most likely due to the rheumatoid arthritis. Then we have another patient, for example, who's very old and he complains that the pain gets worse throughout the day. Whenever I try to function in my life, whenever I try to walk, it worsens with movement, and improves with rest. So most probably based on his history as well as doing your physicals as well as confirming your diagnosis by imaging, you can confirm that the bone pain is due to osteoarthritis. You can see there's a joint space narrowing, you can see osteophytes, and you can see how the joints or the bones are literally sticking to each other. The cartilage weared out, so it's a wear and tear disease. Now you can confirm that the MSK pain is due to osteoarthritis. Okay, if I gave you this image without telling you history on physical exam, you might say that it might be an infectious cause or it might be a tumor. So this shows you how important it is to take history and perform physical examination on patients in order to reach up a probable diagnosis. So, for example, the patient might tell you that he's been losing weight for the past months. He denies any, for example, wear and tear or conditions that mimic bone pain. And based on that, and based on physical examination and imaging, you confirm that there's an radiolucent lesion right here. And most probably it's because of a tumor invading this area. It might be primary tumors arising from the bone itself, usually in the child population, or it can be a metastatic or a secondary tumor that metastasizes to the bone. For example, prostate cancer likes to metastasize to bones. So based on that, you confirm that the MSK pain is due to tumors. Then we have MSK pain due to metabolic changes in the bone, most commonly the osteoporosis. So what happens in osteoporosis is the bones become brittle and weak, and they are at increased risk of fracture. So this is the normal lumbar spines. And the other side, you can see that the lumbar spine became wedge shaped due to compression. And this is because of how weak this lumbar spine is and how compression led it to be wedge shaped. And this confirms that the bone pain is due to osteoporosis. Okay, so why are we concerned about the underlying cause of this bone pain? Because depending on the bone pain, we treat. If it's a fracture, we try to fix the fracture. If it's, for example, due to an infectious cause, we give antibiotics. We drain the joint or the bone, for example, or the pus. If it's inflammatory, we give anti-inflammatory. If it's a tumor, we give chemotherapy, for example. So depending on the cause of the pain or the cause of the bone pain, we manage. So since we're talking about bone pain, so it has to be that the first line is treating the pain itself. So we give NSAIDs, for example. Physiotherapy is important to restore the joint stability, for example. It strengthens the muscles. It is really important, a conservative therapy when dealing with joint pain or MSK pain in general. And then we have injections like corticosteroid injections. They're helpful in conditions that are inflammatory to decrease the inflammation. Then if there are indications for surgery, for example, if it's a fracture, then we can go with surgery. If the conservative management failed, we can then go with surgery as last line. Moving on to arthralgia. What is arthralgia? It's basically inflammation of the joints. So, what are the most common causes of joint pain? It includes trauma, osteoarthritis, inflammatory arthritis, tumor, infection. And how can we know the underlying cause of the joint pain? So of course, we have to start with history taking as well as physical examination because they are considered 90% of getting the diagnosis. And we just use imaging to confirm our differentials or to confirm our most probable diagnosis. So it's very important to take history and do physical examination to reach out the underlying cause of the joint pain. So, for example, in traumas, it would be a sudden, acute trauma that happens that led to the joint pain. Also, arthritis, for example, is with age, it's a wear and tear. Inflammatory arthritis, you have a lot of systemic conditions that affects not only the joints but the whole body. Tumor, you have signs of tumor, like for example, weight loss, loss of appetite, night sweats, infection. You can have all signs of inflammation, things like swelling, hotness, redness, loss of function, and pain. So, based on history and physical examination, we can reach our most probable underlying cause of the joint pain. Okay, this is really important because some MCQs can arise from those. So, the joint pain can be intra-articular pain or extra articular. So the pain could be inside the articulation, the joint itself, or outside the joint itself. So examples of intra-articular joint pain or things that might get affected or might lead to joint pain, which is the joint line. For example, the line between the in the shoulder joints, we have the humeral head as well as the glenoid. So the joint line, if it's affected, it might lead to pain. Cartilage that articulates or that aligns the surface of the bones might also cause the pain. We have the labrum, we have the meniscus, we have the synovium or the synovial fluid. So all of these are examples of intra-articular causes of joint pain. Then we have examples of extra-articular. It could be ligaments, for example. It could be tendons. It could be the subcutaneous tissue surrounding the joint. So most probably an MCQ would ask you, for example, which of the following is not an example of intra-articular cause of joint pain, then you would choose, for example, ligaments or tendons or subcutaneous tissue. Okay, so how can we approach joint pain or joint problems in general? We mentioned that we take history first. We ask about the site, the onset, when did it start, how did it start? Because based on that, we can know whether it's an acute condition or it's a chronic condition. And we also ask about things that makes it better, things that makes it worse, to know what might be the general treatment or the underlying cause as well. We do the physical exam. It's really important to look for signs of inflammation, to look at the joint itself, whether there are signs of inflammation like redness, hotness, swelling, pain, loss of function. Also, you have to feel the joint itself, whether you can feel if it's warm, for example. You try to move the joint actively and passively to assess the range of motion. And we also, you have to assess the nerve as well as the vasculature, whether there's also like nerve problems or blood supply problems. So this might be, for example, the underlying cause for causing the joint pain, or for example, the joint pain affected the joint that led the nerves being also affected as well as the vasculature. Then we move on the X-rays, which includes taking X-rays from different point of views in order to get an idea about the underlying disease. So we take X-rays in the AP position, lateral, and sometimes we even take it standing, especially in the lower extremities, for example, the hips, for the knees, the foot. If there's, for example, you're suspecting there's joint narrowing in the knee, for example, you order a standing X-ray to see this joint narrowing. Then we have some advanced imaging like CT, MRI, as well as ultrasound. Okay, so we have to assess and to look for the presentation. How would the patients present? We look at the quality of the pain, whether it's a sharp pain or dull pain, if the pain arises with motion or not, if there are any signs of swelling or numbness, like here, if there's activity limitation or morning stiffness, for example, that doesn't allow the full movement of the joint, if there are also other conditions involving other systems, for example. This might signify or hint towards rheumatoid arthritis, for example, since it's a systemic disease. So you can see here there are signs of swelling and redness. It's a bruise here, right here. So you could rule out, for example, rheumatoid arthritis, because this wouldn't be the presentation of rheumatoid arthritis, a bruise. You could see how some joint pain or joint diseases led to deformities. Here, for example, this is also arthritis. You can see there's cartilage loss as well as osteophytes, and you can see joint space narrowing that is done on X-ray. We tell the patient to stand, and you can assess the joint space narrowing. Okay, so how can we manage? Always, depending on the underlying cause. If it's, for example, septic arthritis, you have to give antibiotics and drain the pus. If it's, for example, a trauma, you try to fix it non-surgically or surgically. If it's inflammatory, you give anti-inflammatory. So based on the underlying cause, you treat. And in general, we have the non-operative and the operative treatment. The non-operative includes physiotherapy, as we mentioned, that it tries to restore the function, it strengthens the surrounding muscles, and it stabilizes the joint more. We can also give NSAIDs for pain, and we can give injections, like, for example, corticosteroid injections in case of severe inflammation of the joints. Then we have the operative, which includes joint replacement. We can also do fixation in case there is a fracture or trauma. We can do resection or removal of the pus as well as the septic joint. Right. Moving on to neuromuscular injury. So this includes the neurons as well as the muscles. So the injury could be to the neurons themselves or the muscles or both the neurons and the muscles. So we have different causes of neuromuscular weakness. It could be due to spinal cord causes. It could be to motor nerve causes. It could be due to neuromuscular junction causes. It could be due to muscles itself. So under the spinal cord, the most common is trauma and tumor. Then in motor nerves, the most common is ALS as well as the cervical spondylosis. Then moving on to neuromuscular junction, a classic cause is myasthenia gravis. And finally, if the muscles themselves are affected, as in muscular dystrophy or thyroid disease, it would lead to neuromuscular weakness. So how can we approach nerve injuries? Of course, the first thing is history as well as physical examination. You have to take good history in order to form probable differentials as well as to know more about the chief complaint. Then we do physical examination. We test the reflexes, do movements, move the muscle actively and passively in order to know more about the nerve injury or whether it's a muscular injury. Then comes the investigations. And this time we're not going to use imaging that much. So if we want to know about more about the nerve injury, we are not going to use, for example, X-rays or CTs or MRIs. This time we're going to use nerve conduction studies or electromyography. And the good thing or the best thing about electromyography it that it tests the nerve as well as the muscle. So it has two screens testing the muscles as well as the nerves in order to know if the underlying problem is caused by the nerve or caused by the muscle or caused by both the nerve and the muscle. Okay, so let's talk about the peripheral nerve because peripheral nerves are always involved in injuries. So let's talk about the basics. We have myelinated axons and unmyelinated axons. So the dark black circles are the myelinated axons, and those other circles are the unmyelinated axons. All of these are grouped into fascicles. So this is a fascicle, okay? Surrounding this fascicle or surrounding those myelinated and unmyelinated axons, we have the endoneurium, okay? So this is a peripheral nerve that is made up of fascicles. Inside each fascicle, we have myelinated and unmyelinated axons. These myelinated axons and unmyelinated axons are surrounded by endoneurium. Okay, so this is a fascicle, this is a fascicle, this is a fascicle, and these fascicles, these group of fascicles are surrounded by the perineurium. And finally, the outermost layer surrounding the peripheral nerve is the epineurium. Okay, and of course, the peripheral nerve, it might be motor, sensory, or even mixed. So you have to know this because nerve injuries, we can classify them according to which layers are affected. So surrounding the axons are the myelin sheath, okay? And surrounding the myelinated axons as well as the unmyelinated axons, we have the endoneurium, okay? Those are formed into fascicles. So there are a bunch of fascicles here and there. Between the fascicles, we have the perineurium, and all of the peripheral nerve is surrounded by the epineurium. Okay. Now moving on to how can we classify nerve injuries? We can classify them into neuropraxia, axonotmesis, and neurotmesis. Okay. So what happens in neuropraxia? Basically, it's just the stretch of the peripheral nerve. And this would lead to temporary loss of function that gets regained back in a few days. And sometimes it might also cause pain, especially in fractures. Whenever there's a fracture, there's sometimes stretch of the nerve or neuropraxia, and this is the reason why it causes pain. All layers are intact. It's just the nerve is being stretched. Nothing is happening, just stretch. Then we have the axonotmesis, which means that there are some injuries to the nerve, but the outer layer, the outermost layer is still intact. So maybe the endoneurium is not intact, maybe the perineurium is not intact, but for sure, the epineurium is still intact. Okay? Then we have the neurotmesis, which means complete transection of the peripheral nerve, which means all layers are transected. Okay, so why do we classify nerve injuries? Because depending on the type, we have prognosis. So, for example, the neuropraxia has the best prognosis because it's just a slight stretch of the nerve with the intact of all three layers, all nerves, all nerve layers. So it has the best prognosis and you regain the function back shortly. Then we have the axonotmesis, which doesn't have the best prognosis, but it's much better than neurotmesis since the outer layer is still intact. The regain of function usually takes a long time and it's a difficult process. But the worst prognosis is the neurotemesis, which is the complete transection of the whole peripheral nerve of all three layers. Okay, and this has the worst prognosis. Now, moving on to a condition that is called carpal tunnel syndrome. What the doctor wants you to know is that it's a type of nerve injury. So, how can we diagnose it? Of course, we start with history, we start with physical exam, and if we want to go with investigations, we go with nerve studies as well as EMG in order, since it's an injury to the nerve, we need to investigate and test the nerves. Okay, so what are the causes of carpal tunnel syndrome? The most common cause is the nerve entrapment, which affects the median nerve, and this would lead to numbness in the thumb as well as the three fingers, sparing the pinky. Okay, so patients would feel numb, they would feel sometimes pain, as well as they would feel weakness. Then we have direct trauma, and the most common fracture that would lead to carpal tunnel syndrome is the distal radius fracture. You have to know this. Then we have other causes, like for example, third spacing. Third spacing happens when there's fluid retention. In conditions like hypothyroidism, in pregnancy, in diabetes, in chronic kidney disease, for example, there is fluid retention, and this retention or fluid retention causes pressure on the nerve. So it would cause pressure on the median nerve, leading to carpal tunnel syndrome. Then we also have tumors, for example, especially tumors that compress the median nerve would also manifest as carpal tunnel syndrome. And that's all about neuromuscular injuries. Moving on to orthopedics and sport, and starting with ACL tear or anterior cruciate ligament tear. So let's start with the basics. What is the ACL? So the ACL or the anterior cruciate ligament is one of the four major ligaments in our knee joint. This ligament lies deep inside the knee and plays a crucial role in maintaining the knee stability. So, although the ACL is located inside the capsule, the joint capsule, it is described as extrasynovial, which means it is not directly covered by synovial fluid. And this is very important because this affects the healing potential or the healing effect of ACL. So that's why when we have complete ACL tears, we don't those tears do not heal well on their own. So the ACL is composed of two functional bundles. The first bundle is the anteromedial bundle, which becomes tight when the knee is bent or flexed. Then we have the second bundle, which is the posterolateral bundle, which becomes tight when the knee is straight or extended. So these two bundles together ensure that the knee remains stable throughout its entire range of motion. Anatomically, the ACL originates from the lateral femoral condyle, which is basically the outer part of the lower end of the thigh bone. Then this ligament then runs downward and forward to insert on the anterior part of the tibia. So, functionally, the ACL prevents the tibia from sliding forward relative to the femur and also limits excessive rotation of the knee, especially during sudden movements such as, for example, cutting or pivoting or also landing from a jump. Okay, so ACL injuries, we mentioned they are particularly common in sports that involve rapid changes in direction, such as jumping and sudden stopping. And these sports include football, basketball, skiing, as well as handball. So, female athletes have a higher risk of ACL injury, and this is due to several factors, including that the females have a wider pelvic anatomy, they have differences in muscle activation patterns, as well as they have hormonal influences on the ligament laxity. So, most ACL tears occur without direct contact. So, a typical injury scenario is when an athlete, for example, plants their foot on the ground and suddenly changes direction. This creates a rotational force and valgus stress across the knee, which then leads which then the ACL cannot tolerate and leads to ACL tear. Less commonly, the ligament itself can be torn by a direct blow to the lateral side of the knee, forcing it inward. So, what would be the clinical presentation of ACL tear? So, patients with ACL tear often describe a very classic history. So, at the moment of injury, they may hear a or feel a sudden pop inside the knee. This is an important clue. And almost immediately, the knee becomes very painful and unstable. And within hours, there is significant swelling that develops around the knee joint. This swelling is due to the bleeding inside the joint, a condition known as hemarthrosis. This happens because the ACL is well vascularized, so when it ruptures, it leads to rapid accumulation of blood in the joint. So, as a result of the pain, swelling, and instability, patients are usually unable to continue playing or bearing weight. And with time, especially if the injury is not treated appropriately, patients may experience repeated episodes where the knee gives way during everyday activities or sports, and this increases the risk of further damage. Okay, so how can we examine or perform some physical examination tests on ACL tears? So, in order to assess the ACL integrity, we have several specific tests that we can use, starting with the latchman test. It's considered actually the most sensitive test in order to assess the ACL integrity. It is performed when the knee is slightly flexed at about 20 to 30 degrees. So what happens is that the examiner stabilizes the femur and pulls the tibia forward. This excessive forward movement compared to the opposite knee suggests an ACL tear. Then we have the anterior drawer test, which is performed with the knee bent at 90 degrees. Although it is useful, it is less reliable, especially in acute injuries, because in acute injuries, muscle spasm may limit the movement of the joint, so you cannot assess it well. Then we have the pivot shift test. So the pivot shift test evaluates the rotational instability, and it is very highly specific for ACL deficiency. But however, downside is that it is often difficult to perform, especially in awake patients, because it causes a lot of discomfort as well as apprehension. So after doing physical examination, we move on to imaging. And X-rays are usually the first imaging study obtained in order to exclude fractures. And on imaging, on X-rays, one important radiographic sign is the second fracture, which is basically a small avulsion fracture of the lateral tibial plateau. Although this fracture appears very small, it is highly suggestive of an underlying ACL tear. But the gold standard, it is MRI. So MRI is the gold standard for diagnosing ACL injuries. This allows the MRI imaging allows us to visualize the ligaments as well as assess its integrity. And also, MRI identifies associated injuries, which are very common in ACL tears. So the most frequent associated injury is the lateral meniscus tear, and this occurs in about 50% of cases. We could also see some bone bruises of the lateral femoral condyle as well as the tibial plateau. So after diagnosing, how can we manage? Management of ACL injuries, they depend on the patient's activity level as well as expectations. We can divide management into non-operative as well as into operative. So non-operative management includes physiotherapy, and the physiotherapy focuses on strengthening the muscles like the quadriceps as well as the hamstrings, also improving proprioception as well as using a brace when necessary. This approach, the non-operative approach, may be suitable for older patients or for sedentary patients. But in contrast, the definitive treatment is surgical reconstruction of the ACL joint. And it is actually recommended for athletes as well as physically active individuals. So what does the surgery do? The surgery aims to restore knee stability. It also prevents recurrent giving way episodes. It protects the menisci, and it also reduces the long-term risk of early osteoarthritis. Moving on to another entity, which is shoulder instability. So, the shoulder joint is the most mobile joint in the human body. And this mobility comes at the expense of stability, making this shoulder joint particularly prone to dislocation. So, whenever you have more mobility, it leads to more prone to dislocation. Since the shoulder joint is the most mobile joint, it is actually the most joint prone to dislocation. So the stability of this joint is maintained by two main systems. We have the static stabilizers as well as the dynamic stabilizers. Starting with the static stabilizers, which include the glenoid labrium. And this deepens the socket and allows to stabilize the joint. We also have the glenohumeral ligaments and as well as the negative pressure inside the joint that helps hold the humeral head in place. Then we have the dynamic stabilizers, which include the rotator cuff muscles as well as muscles that control the scapular movement. These muscles actively center the humeral head within the glenoid during motion. So the most common type of shoulder instability is the anterior shoulder instability because the anterior stabilizing structures are relatively weaker. So what would be the clinical history and the risk factors? So, one of the most important predictors of recurrent shoulder instability is the age at which the first dislocation occurs. So, younger patients have a much higher likelihood of repeated dislocations. So, what would be the symptoms? So, patients often describe a feeling that the shoulder is slipping out of place, particularly during overhead movements or throwing activities. The classic mechanism of injury involves the arm being forced into abduction and external rotation. Moving on with physical examination tests and starting with the apprehension test. So the apprehension test assesses the shoulder instability by placing the joint in a vulnerable position. So a positive test occurs when the patient expresses fear or apprehension that the shoulder will dislocate. Then we have the relocation test, which basically a test that is performed by applying posterior force to the humeral head, which reduces symptoms and confirms instability. Then we have the load and shift test, which evaluates how much the humeral head can translate within the glenoid. As well as we have the Brighton score, which is used to assess the generalized joint hypermobility, which can contribute to shoulder instability. And having 4 or more out of 9 indicates hypermobility. Moving on to complications. So imaging is important in assessing the extent of damage. On X-ray, we could find some lesions, starting with the first lesion, which is called Hill-Sachs lesion. It is basically a compression fracture of the posterior superior humeral head that is caused by the impact against the glenoid rim. Then we have Bankart lesion, which basically refers to the detachment of the anterior inferior labrum. And glenoid bone loss happens when there is bone loss of 25% or more, and all of these compromises the stability of the joint, as well as often requires a bone blocking procedure, such as a procedure called lateral jet. All right, moving on to the last entity, which is the base of fifth metatarsal fractures. So, the base of the fifth metatarsal has a unique and clinically important blood supply. At the junction between the metaphysis and the diaphysis lies a watershed zone, and this watershed zone has limited blood flow. So this explains why fractures in this region have a high risk of delayed union or non-union. So most common mechanism of these fractures, they occur due to an invergent injury of the ankle where the foot twists inward. So how can we classify those fractures? So we use the torque classification. The torque classification divides the fifth metatarsal fractures into three zones based on location as well as the healing potential. Starting with the zone one fractures. They are basically avulsion injuries caused by traction from the peroneus brevis tendon or plantar fascia. So, if an injury happens in zone one, this would lead to injuries caused by traction of the from the peroneus brevis tendon or the plantar fascia, and they are generally they heal very well. Then we have the zone 2 fractures, which is also known as Jones fractures. They occur in the watershed zone and they have a higher risk of non-reunion. Finally, we have the zone 3 fractures. They are stress fractures of the proximal diaphysis, often seen in athletes due to repetitive loading. So, how can we diagnose and manage? So, we use the Ottawa anchor rule in order to help determine when x-rays are required or not, especially when there's tenderness at the base of the fifth metatarsal. So, how can we manage? Manage depends on the fracture zone. If it's zone 1 fractures, they are treated conservatively with supportive footwear. If they are zone 2 fractures, they often require non-weight bearing and may need surgical fixation in athletes. Then we have zone 3 fractures, which usually require surgery due to poor healing potential. Right. Let's start with sports medicine, starting with upper limb trauma. So, whenever a patient comes to you, with an upper limb problem or upper limb fracture, you need to know where exactly is the fracture. So, the fracture could be in the proximal humerus, it could be clavicle, scapula, humeral shaft, distal humerus, elbow, forearm, distal radius, or hand. So, how can we identify the exact location based on imaging? So, once we take history and do physical exam and we confirm our diagnosis that it is really a fracture using imaging, you have to anatomically locate the exact area or which part of the upper limb is exactly affected or fractured. Then moving on to the etiology or the causes for upper limb fractures. It could be divided into high energy trauma or low energy trauma. So high energy trauma includes motor vehicle accident or falls, especially from falls that are very high, and gunshot wound. Low energy trauma includes fall from on height, twisting injuries, for example, as you were playing, for example, then you twisted your upper limb, or it could be a simple activity, for example, falling from the chair or falling from the bed. So all of these are considered low energy trauma, and you have to able to be able to differentiate between high energy trauma causes and low energy trauma causes because the management and the treatment differs. Why are we concerned so much about high energy trauma? Because patients who experience high energy trauma do not only come or do not only present with fractures. This might be the least thing they present with. What we are concerned more about is the vitals. So, high energy trauma could affect the vitals of the patients, making them vitally unstable, or even they could affect their consciousness. So whenever a patient you're suspecting that got into a high energy trauma, you have to make sure first that the vitals are stable and you have to check his consciousness. Then we assess what fractures occurred in the upper limb, right? We talked about this in the LGDs. We talked about the upper limb trauma, things like the proximal humeral fracture. We talked about the mid clavicle fracture that led to displacement and pain. So these are types of upper limb fractures and traumas that everyone could see in the orthopedics department. What else? We could see mid shaft fracture of the humerus. We could see, for example, elbow fracture. As you can see, here's the elbow dislocation as well as fracture. The forearm might be affected. As you guys can see, the radius and the ulna are fractured. And here is the most common fracture in elderly, which is the distal radius fracture. So, as we said, after history and physical exam, we confirm that it is actually fracture using imaging, and we have to know the exact area of the fracture. Okay. And also we have to assess whether it's a closed or open fracture, because open fracture, it means that the bone breached the skin and it led to open sites. Uh, Very easy for the infection to go into, or bacteria to go into. So this needs more care, wound care, as well as administration of antibiotics. We have also to assess whether there is a nerve injury or even vascular injury. Then the management could be divided into acute and definitive management. So sometimes the acute management might be the definitive management, but but other times we could have an acute management, then like 2 weeks later or something, we could have the definitive management. For example, um, if someone fractured his upper limb, the acute management might be the sling, for example, or the cast. And this also might be the definitive management. For example, but for other conditions, for example, if a patient needs surgery, but you have to manage him acutely first. So first thing you do immobilization, then you can do surgeries, for example, after a week or so. So you have to know the idea or the difference between acute and the definitive management. As well as we talked about the surgical and non-surgical. We mentioned that the non-surgical includes immobilization, things like applying sling, cast, uh, doing non-weight bearing things. And then surgically, we have the CRPP, the ORF, and the external fixation. So from the sports medicine aspect, the doctor wants you to know that the most common upper limb trauma, or most common upper limb sports injury, is the shoulder dislocation. And why does it happen? Because the shoulder is a ball and socket. It is freely movable. It's actually the most movable joint in our body. So whenever we have more mobility or more freedom, there's an increased risk of injuries or dislocation. And you know that the ball and socket allows for multi-axial movement. So that's why the shoulder joint is actually the most common sports injury in the government. Then we have other sports injury that you can find, which is the acromioclavicular dislocation. We can have also the TFCC. This is a wrist injury that happens in the pinky side of the wrist. It's usually due to repetitive movements like the golf or tennis, and it affects the wrist from the pinky side. And it's common also as a sports injury. Now, moving on to lower limb trauma, the same exact thing. We have to know the anatomy, the location of the lower limb fracture, whether it's pelvic trauma, femoral head or neck fracture, intertrochanteric fracture, femoral shaft, distal femur, tibial, ankle, or foot. And the etiology is the same. Whether it's high energy trauma, this includes the motor vehicle accident, the fall, the gunshot wound, or the low energy trauma, which includes the fall from on height, twisting injury, and simple activity. And whenever you suspect someone with high energy trauma, first thing you have to make sure that the patient is vitally stable, he's conscious. Then you assess what fractures occurred. We talked about this in LGDs. We could have different types of fractures. We could have the femoral neck fracture. We could have dislocations. We could have the femoral shaft fracture. We could also have intertrochanteric fracture. We could have the patellar fracture. We could have proximal tibial fracture. We could have also fracture of the shaft of the tibia as well as the fibula. We could have even displacement and fracture of the ankle, and this is a picture of treating it. So what I want you to know is that you need to know the location of the lower limb trauma, the exact anatomical location, because based on that you manage. You also assess whether the trauma is closed or open, and we mentioned that open has high risk of bacterial infection as well as vascular damage. So make sure to ensure proper wound care as well as giving antibiotics if you're suspecting bacterial infection. You have to assess if there's nerve injury as well as vascular injury. There's also acute and definitive management. We could sometimes manage patient acutely, then few days we do the surgery as a definitive management. And we can divide the management into surgical and non-surgical. The same thing, non-surgical, you immobilize the joint or the bone in order to prevent movement. Things like sling, non-weight bearing, cast. Then we have the surgical, which is the CRPP, or if external fixation. You don't need to know every single detail. You have to know just whether the wound is closed or open, there is nerve injury or not, there's vascular injury or not, what could be the acute treatment and the definitive management. The management could be non-surgical as well as surgical. And from the sports medicine aspect, you have to know that the most common lower limb injury, sports injury, is the ACL tear due to twisting. And to remind you, the most common upper limb sports injury in the government is shoulder dislocation, which is a labrum injury that happens in the upper limb. All right, moving on to joint and ligament injuries. So we already covered types of joints. We talked about pivot joints, ball and socket, condyloid, saddle, hinge, gliding joints. So we mentioned that ball and socket joints include the shoulder joint as well as the hip joint. We talked about the hinge joint, which includes the elbow and the knee joint. So what are the most common joints involved? We have the shoulder, the elbow, the wrist, the hip, the knee, and the ankle. So what would it present clinically? So if a patient has a joint problem, how would they present clinically? Depending on the etiology, it could be a traumatic etiology, it could be inflammation, it could be tumor, it could be infectious. So depending on the etiology, the patient would present clinically. And how do we approach these injuries? The usual, the same thing. We start with history taking, physical examination, then we confirm our diagnosis by doing investigations. And how do we manage? Also the same. We have the non-operative and the operative treatment. Okay, let's start with shoulder joint. So it could the shoulder itself could be injured or the ligaments around it could be injured. Let's start with reasons for joint injury. It includes fracture, it includes arthrosis or arthritis. It also includes necrosis or avascular necrosis of the shoulder joint. And this is most commonly found in patients with sickle cell disease because not enough blood supply is going to this joint. This leads to avascular necrosis of the shoulder joint. Then we have septic causes. This is due to microbes or bacteria. Then moving on to ligament injury, we could have the glenohumeral dislocation due to the labrum. We could also have AC or acromioclavicular separation. We could also have some rotator cuff pathologies happening in the joint. Then comes the elbow, also joint injury and ligament injury. So joint injury includes fracture, especially the radial head fracture or the distal humerus fracture. And we also have arthrosis, things like osteoarthritis or rheumatoid arthritis. We also have necrosis as well as septic causes. Then moving on to the ligaments. So from the medial side, we have the MCL or the medial collateral ligament, and also in the medial side, we have the CFO. Okay, so those are in the medial side of the elbow. In the lateral side, we have the LCL or lateral collateral ligament, and we have the CEO. So those ligaments could get injured. So the LCL could get injured, or the MCL, for example. And in tennis elbow, the CEO gets injured. So the CEO is the common extensor origin, and this ligament gets affected in tennis elbow, while the golfer elbow, the CFO or the common flexor origin is the one that gets affected. So a way to remember this is that the F in CFO and the F in golfer, they are same. So this is how you can remember it. And if you are COO, you don't worry that much, so you play tennis. That's why. Okay. We could also have triceps and biceps distal rupture. Just want to tell you here that in tennis elbow, the lateral epicondyle is affected, and which ligament is affected? It is the CEO. On the other side, and the golfer's elbow, the medial epicondyle is affected, and which ligaments is affected? It's the CFO. Okay, moving on to the wrist. So, joint injuries include fracture, especially the distal radius fracture, as well as the scaphoid fracture. Then we have arthritis, things like osteoarthritis or rheumatoid arthritis, as well as septic. Then moving on to ligaments, we have the scapholunate ligament, which is the ligament that joins scaphoid with lunate. It also could get injured. We have also the distal radio-ulnar joint, which is the joint that joins the radius and the ulna in the distal aspect, and this allows the rotation of the forearm. Then we have the TFCC. We mentioned this that it is found in the ulnar side. It's basically a menisci that stabilizes the ulnar side or the pinky side of the wrist. So it could also get injured. Moving on to the hip joint. So fractures could happen to the femoral head or the acetabulum. Also, we could have arthritis, things like osteoarthritis, rheumatoid arthritis, avascular necrosis. It could also be septic arthritis, and we have some ligaments. So the labrum itself could be affected, or the tendons of the muscles surrounding the hip joint. Now, the knee joint. So we mentioned also there's joint injury and ligament injury. Fractures could include the femoral condyle fractures, as well as the patellar fractures, or the tibial plateau fractures. And we could see also arthritis, rheumatoid arthritis, as well as OCD lesions. So OCD lesions are basically parts of bones or cartilage that didn't get enough blood supply, and they got separated from their normal part of the bone or the cartilage. And this is an OCD lesion. Or it could be septic also. Then moving on to the ligaments, we could have injury to the menisci. We could have injury to the anterior cruciate ligament, which is the most common lower limb sports injury. We could have an injury to the PCL, which is found right here. We could have injury to the LCL as well as the MCL. We could also have an injury to the capsule or to the muscles surrounding the knee joints, like the hamstring, the quadriceps, as well as the patellar tendons. Moving on to the ankle. So, also joint injury and ligament injury. We could have fractures to the lateral malleolus or the medial malleolus or trimal. Trimal includes the medial malleolus, the lateral malleolus, as well as the posterior malleolus. So the medial malleolus comes from the tibia, as well as the posterior malleolus comes from the tibia, and the lateral malleolus comes from the fibula. We could also have arthrosis, things like osteoarthritis, rheumatoid arthritis, as well as OCD lesions. It could be septic, and we could also have ligament injury, things like ankle strain, which affects, in that case, the ATFL, which affects the distal aspect, or the deltoid, which affects the medial aspect of the ankle, or there could be a tear in the syndesmosis, which is the joint that joins the bones of the tibia and the fibula. And that's all about joint and ligament injuries. Moving on to the last topic in sports medicine, which is approach to MSK disorders and deformities. So, whenever you have MSK disorder or a patient comes to you with an MSK problem, you have to know the underlying cause or the etiology behind it. So, what are the etiologies in general? It could be due to trauma, due to infectious causes, due to inflammatory causes, and these include vasculitis as well as vascular occlusion and necrosis, vascular necrosis. It could be due to neoplastic and oncological causes. It could be degenerative, or it could be metabolic. So how can we know the underlying etiology for this MSK problem? So basically, and we said it multiple times, we start with history. So if a patient comes, for example, with MSK disorder, we ask if there's pain. And whenever there is pain, we ask more about the pain. Is it sharp or dull at the site, the onset, the character? A patient might come with a cosmetic problem, is complaining of a deformity. And we're going to discuss what are deformities. Um, Patient could come with limited function. The joints are not working, for example, or they're not cannot move their joints well. So based on history, you know more about the chief complaint, and not only that, you form differentials as well as you know more what could be the underlying etiology for this MSK problem. So we ask also about a lot of things, including the acute, the onset, whether it's acute or insidious, the duration, is it self-limited or chronic? We ask about the number of joints infected, if it's monoarthritis, meaning one joint is infected or affected, or oligoarthritis, which includes few joints affected, or polyarthritis, so many joints. Is the distribution symmetrical all over the body or in specific area of the body? Localization, is it peripheral or axial or both? So based on history, as I said, we know more about the chief complaint and we can form differentials based on the presenting illness. So after taking history, you go on to proceed with physical examination. You look for tender points, you inspect the deformity, you move the joint, for example, actively and passively to see if there's limited function, and then we go with investigations. But this is in general with MSK disorders. Now I'm going to shift more into a specific condition, which is deformity. A deformity is basically any bone that is growing in an abnormal way or abnormal shape, or growing or healing in an abnormal shape. So, if a patient comes to the clinic complaining of a cosmetic problem in his body, so you have to take history. It could be due to trauma or infection, or it could be any cause that led to deformity. So, also in physical examination, you check the deformity itself, and if you are suspecting a deformity, during the investigations, we have to order full length X-ray because you cannot assess the deformity by just looking at the picture from a small point of view. You have to zoom out and look and compare also both sides of the body. Then we can order also blood tests or other investigations in order to rule out or rule in etiologies. Okay, so we are going to talk about deformity. So what is adult limb deformity is basically a condition that can result from different causes, like childhood growth impairment, metabolic bone disorders, severe osteoarthritis, trauma, or fractures. Okay, and in order to diagnose a deformity, you need, of course, to start with history as well as physical and clinical examination, and you have to take a plain full limb length radiographs. So if you're suspecting a deformity in the lower limb, you have to take an X-ray from the hip till the ankle. If you're suspecting, for example, a deformity in the humerus, for example, or the shoulder, so you take an X-ray from the shoulder till the wrist in order to be able to visualize this deformity and to be able to compare not only one side but with both sides. So, for example, we have a patient who's coming to the clinic complaining of pain in his left knee, and he mentions that the left knee doesn't look like the right knee. So after taking history as well as physical examination and X-ray, we of course order a full limb length X-ray to visualize everything. Okay, so when drawing a line from the middle of the femoral head till the middle of the ankle, normally the line should pass through the midline of the knee joint. But what happens here is that the apex of the knee joint is tilted to the inside. So, for example, if you drew a line here till here, you find that the line is passing through the midline of the knee. But on the other side, the knee is tilted towards the inward or inside, indicating a deformity. And this is called genus valgum, which means that the apex of the joint is moving inward. All right. And this is a photo showing how they fixed the joint. And when they drew a line axis, it normally passes through the midline of the knee joint. We also have spinal deformities, things like scoliosis. So it's idiopathic or degenerative condition that leads to deformity that affects the coronal as well as the sagittal plane of the spine. So as you can see on the coronal image, you can see how the spine is affected, and also in the on the sagittal plane you can see how there's bending of the spine, which indicates kyphosis. So how can we diagnose? Of course, by clinical history, physical examination, and taking a full length of the whole spine or the spinal cord of the body. And how do we treat this? We usually start with non-operative treatment because usually they complain of pain. So we start with NSAIDs as well as physiotherapy in order to try to bring the spine as much as we can to the normal anatomy. But if the non-operative management failed, the surgical treatment or surgical correction is the definitive treatment, especially for patients that have disabling pain, or they failed the non-operative treatment, or they have progressive neurological deficits. So as you can see, here's the deformity fixation. They tried to bring the spinal cord or the spine as much as they can to the normal shape. Then we have a patient that is complaining of unequal limbs. So by clinical history and physical examination, as well as full limb length x-ray, you find there is leg limb discrepancy. You can see that the tibia and the fibula are normal on both sides, but when you compare the femur on the left and on the right, there is a discrepancy or difference in the femur length. And this could be assessed by the number of blocks needed in order to be equal. So this indicates the amount of length missed on the right femur. And also we assess the leg length discrepancy using different axes in order to visualize the whole underlying pathology. Or here in the right image, when you draw a line from the head of the femur till the ankle, you can see that here it is normal, but the on the right knee or the right leg, you can see that the knee or the apex of the knee is tilted towards the inside, indicating genu valgum. And this shows how can instruments be used to fix limb deformities. Things like the external fixator, or called the frame, in which the pins are inserted through the skin and to the bone in order to fixate it and to correct the deformity. The problem with this is that if no proper wound care is done, it could lead to infection in those openings or the sites where the pins enter through the skin as well as the bone. So we, on the left side, when we draw an axis from the head of the femur till the ankle, you can see that the knee is, or the apex of the knee is towards the inside. So this is genu valgum. On the other side, when you draw an axis from the head of the femur till the ankle, you can see that the apex of the joint is away, so away from the midline. So this indicates genu varum. So a way to remember is that valgum, it's like a gum, so it sticks to the inside or near the other joint. Varum means far away. So in that case, the patient has genu varum since it is away from the midline to the lateral side, outward. And this also shows genu valgum on both legs. Okay, So this is a patient who had a lot of bad deformities that was treated by using internal fixation, but it didn't work out. So they decided to go with external fixated or deframe, as we mentioned. And the problem with these is that they insert the pins or they fix the bones by inserting pins through the skin as well as through the bone itself. Although it's effective, but it could lead to a lot of complications. And of those complications is infection. If the pins are not properly cleaned, if the sites are not properly cleaned, then it could lead to infection to those sites and it could lead to inflammation as well as swelling or even pus formation. So it could reach a point that we could even remove those pins, clean the wounds, and return back those pins. So we have to make sure that we maintain proper wound care for those sites in order to prevent infection and the complications of these infections. So how can we manage deformities? It could be divided into non-operative management and operative management. For example, these are tools or devices that are used to treat soft tissue injuries rather than deformities. And this is a type of surgery that is called growth modulation, in which if a person has an anticipated bone deformity, they limit the growth of this bone by modulating the growth plate. So depending on the management, depending on the underlying cause and the condition, we treat based on the disease itself or the deformity itself. All right, this concludes our crash course. I hope you guys really enjoyed it, as well as I hope that it was helpful. If you have any questions for me, please don't hesitate to reach out to me. As well as don't forget to scan the QR code for your feedback. It would be greatly appreciated. I wish you all the very best luck in your MSI exam. And yeah, good luck and thank you for listening. Bye bye.